Well, welcome everybody to the Telehealth Summit. My name is Jason Brodeur, and I am the chairman of Health Innovation in the Florida House of Representatives. I really appreciate all of you being here. What I want to do briefly is introduce our panel and let them really put a foundation around what it is going on in telehealth today and what we think is possible. We'll wrap up. I'll give a few words on some recently filed legislation in telehealth and then take questions from the audience, if that's all right with everyone. I'll start down at the far end. We've got Scott Simmons, who's the director of telehealth at the University of Miami School of Medicine. We've got in the middle Dr. Michael Bess, who's the national medical director of telehealth for Optum. And then sitting next to me is Travis Bond, who's the CEO of CareSync, an application that allows individuals to have their own data and take it with them on their smartphones, tablets, and online. And so with that, I think I will first give up the floor to Dr. Bess, who will then go through his introduction to telehealth. Dr. Bess.
Hello, hi, I'm Mike Bess. This is an exciting time to be a part of telehealth. You have venture capital, large organizations, academic institutions, and that's pretty much represented by the panel that you have here. Certainly, we're trying to find solutions to help decrease costs. I'm going to talk about provider extension solutions that we've created at United Health Group. Certainly, there's a challenge. How do we expand access to healthcare when there's a provider shortage? How do we decrease costs? Costs are escalating every year, and certainly that's important to employers. How can we make it so that the solutions are cost-effective and still provide the same level of care to patients? There needs to be improved coordination of care. The speaker before us obviously discussed that in several parts of his discussion, and I think that using technology to facilitate this is going to help in the future. And we need to reduce admissions. There's been several policy reforms that have caused increased focus on this, and technology is one of those ways to effectively reduce costs and quality. Trying to get specialty and subspecialty resources to people in rural areas so that they don't actually have to drive or make that commute to get the care. Some of the solution dynamics that we see, rapidly decreasing cost of consumer technology. Every one of you, I'm sure, has smartphone, tablets, internet access, and this is pretty much nationwide that people have access to this technology, and it's affordable at this time. Digitalized diagnostic equipment. Our physician last night discussed that he has an EKG on his iPhone. These solutions are so easy and adaptable at this point that it has caused us to have increased focus on this market segment, and secure transmission capabilities for regulatory issues, reimbursement model improvements, and consumer interest and experience. We at United Health Group have a full suite of telehealth solutions that we are adapting. One is a Now Clinic platform for acute care, convenient care type access, Telepsych for access to psychiatry services, Teleclinic for specialist clinician-to-clinician contact, remote monitoring to try to keep people out of the hospital, and LifeLens. Next slide, please. The part that I'm most involved with is our Now Clinic. This is offering convenient care through telehealth mediums for patients and clients. Certainly, we have found that this is very effective, cost-effective, and have found that quality has made this very resourceful for patients. Next slide, please. Telepsych, here we have psychiatrists by remote monitoring, and they can access patients, whether at nursing homes, emergency departments, to provide psychiatric services where they were not available before. Next slide, please. Teleclinic is a solution that has been developed to offer clinician-to-clinician consultations. These consultations, if you could imagine a tertiary subspecialist, such as an interventional cardiologist at a tertiary center, being able to access a patient from a more remote area so that the patient doesn't have to drive to the facility, or vice versa, having the specialist actually to come to the rural area. Next slide, please. And remote monitoring. This has really got a strong push recently because of the policy of trying to reduce readmissions and save healthcare dollars. What we've discovered here is that we can actually monitor vital signs when we see that the patient is decompensating. Rather than sending them to the emergency department, we can intervene prior to that event and therefore save those readmissions. Next slide, please. And LifeLens. LifeLens is a solution where for remote patients, they can actually tape and send to their specialists their care, such as patients that have seizures, and they can record these and send them to neurologists at the tertiary facility so that they can decide what changes they want to make in treatment. Next slide, please. And finally, discussing Now Clinic a little more, which I am integral part with Optum. Now Clinic is overcoming barriers with telemedicine by access beyond the bricks and mortar for 24/7 coverage, eliminates geographic barriers, reduces burden for ER, which certainly ER needs some help to be reduced, and that's my background. And for employers, having healthier, more productive employees, quality real-time care for consumers. Most patients can access a provider in less than 10 minutes. Reducing healthcare expenditures, we have a proven model and have seen it repeatedly save healthcare dollars when we've implemented it. And quality, we have evidence-based guidelines, scope of practice guidelines. Certainly everything can't be handled through this solution, but defining those makes it much more available to people. And then prescription guidelines. And I will turn it over to Mr. Simmons.
I'd feel more comfortable up here, except I'm not tall. The confidence monitor. So I am tethered to slides a little bit. So I'm Scott Simmons. I'm director of telehealth at the University of Miami. I've been involved in telemedicine, telehealth, e-health, whatever you want to call it. I think they're all substantially equivalent for about 20 years, actually more closer to 22 years. Starting off as an engineer with the U.S. space program in Houston, designing systems for the space shuttle and space station. Then got sucked into academia at East Carolina University School of Medicine, which was interesting because it was very rural. And I was there for about 7 years, and now I've been with University of Miami almost 7 years, which is very urban. So it's, I think, a fairly broad base of telehealth in government and rural and urban areas. So what we'll try to do real briefly is give you a feel for what we're doing at University of Miami as examples to illustrate some of the things we'll talk about, or I'll talk about up front. So first of all, to start with what the value proposition is for telehealth. So the number one and the most obvious one is access, but I would add convenience to this. Our whole health system is built around convenience for the care providers. So we physically travel to healthcare facilities. We do it at hours that are convenient for the providers. And so convenience is really kind of physician or healthcare provider centric, and I think technology changes that. I'll talk a little bit about that at the end. Quality, from our perspective, the idea of being able to get access to academic, kind of the latest evidence in our providers, but you could say that for any up-to-date medical practice. And cost, a lot of the cost comes around, is more around cost avoidance in terms of improved efficiency, reduced travel time. There's a benefit in seeing specialists earlier in treating a condition because there's less of a shotgun approach. So if there's a primary care practice that's managing, let's say, someone with a skin problem, a lot of times they'll try a number of different things, and it's been shown in the literature that if they get access to a dermatologist early on, they get there faster and it's cheaper. So if I were to look from my perspective of how you might differentiate clinical telehealth services, it's similar to how my colleague would do it, but slightly different. So from our perspective as providers, especially consultation, which I would call classic telemedicine, that's kind of how the bread and butter of how this got started, being able for a specialist to provide an interactive examination and opinion at a distance, right? And so we're actually not just doing this interactively anymore, using video conferencing mostly. We're actually doing what's called in the telehealth world store and forward consults, where data are temporarily stored and then the specialist reviews them at some later time. That some later time could be hours or days. And I'll talk some more about that in specific to dermatology, but that's how radiology is done now. Actually, you don't even really hear the term teleradiology anymore, it's just radiology, right? So if you want to provide your consultations on the golf course or at your ski lodge or wherever, that you can do that pretty much anywhere. One thing that we're not that involved in, but as my predecessor had clearly stated, that disease management remote monitoring is huge. And the real value there is detecting preclinical problems. So because you're looking at granular data of physiologic parameters, you're seeing those things start to change before it becomes clinically evident. In other words, before someone calls 911 or before someone actually drives to the emergency department. And then I would say one that's slightly different, and it may be just an operational distinction, is what you might call on-call or on-demand service. And I would differentiate these into two different ways. One is virtual staffing. One of the challenges that hospitals, and I always thought it would be rural hospitals that face this, but there's a lot of suburban hospitals, is getting specialty staff to staff their facilities. And this became immediately evident in the field of neurology, that emergency departments were having trouble getting, especially stroke-certified neurologists, to cover their EDs for a variety of different reasons. But this wasn't happening just rurally. This was happening in Palm Beach County. That's actually one of the most affluent counties in the country, that they couldn't get neurologists to cover the EDs. So once people started to become more aware of stroke care and TPA became available, and EMS departments and EMS systems started dictating that they would only take patients to places that were stroke certified, then that became a real lost business opportunity for these hospital systems. So now with what I wouldn't just call telestroke, but acute teleneurology is the first kind of indicator of this, is that with many of these services, that an emergency department physician can get access to a stroke certified neurologist within 15 minutes of being called. They can make the call whether it's ischemic or hemorrhagic stroke, determine whether they can handle the patient there, whether they need to be transferred for mechanical clot extraction or other advanced procedures. So that's been a real success, but EDs in hospitals really have trouble getting access to other specialists as well, whether those are ophthalmologists or dermatologists or psychiatrists especially. So I think that's a virtual staffing model is one, and another part of this kind of on-call or on-demand part is urgent care, emergent care, and we're doing some work in that area as well. Next slide, please. So I mentioned that there's these two different operational modes. There's this real-time telehealth, usually video conferencing, and the store and forward. Radiology being a good example, but dermatology, it turns out, is one of the most store and forward friendly specialties. We have one of the biggest derm residency programs. The founder of our telemedicine program, Dr. Ann Burdick, is a professor of dermatology, and it's a big shortage area, right? There's long wait times for dermatologists. So as a result, we've done a lot of work in dermatology, and on the store and forward side, we've, I guess, 3 different programs I'll talk about. So one is the cruise ship industry. That's a problem for getting access to care for cruise ship employees as they're sailing around the world. So for both cruise lines, Royal Caribbean and Carnival Cruises, we have contracts to provide 24/7, 365 access to dermatology consult services. And mostly for employees, we see guests occasionally. But you can imagine, it's enough of a problem getting access to dermatologists during normal workday hours on land, but it's even harder at different ports of call as you make. So it was really difficult for these employers to get their employees access to dermatologists when they needed them. So we've been doing this with, I think we're in our 4th year with Royal Caribbean and our 2nd year with Carnival Cruises. Another bit of work we're doing is with U.S. Indian Health Service. Out of the Nashville area office, we've just added a couple other offices where they've been using store and forward dermatology for a long time, as well as a program we just added, which is the Alaska Native Tribal Health Consortium, which is a consortium of, I think, 220 or 224 different sites around the state of Alaska. A lot of these are villages that are only accessible by float plane or by boat. And so that's very much needed. I will speed up. I see someone looking at their watch. Next slide, please. Pediatrics, we've, for about 7 years, been providing specialty consultation services for children's medical services. I think we're in our 4th year now with a 9-school program in Miami-Dade County Schools. And then just within the last year, through support from the Verizon Foundation, we've now telemedicinized a pediatric mobile van that we've had going around impoverished parts of Miami-Dade County since Hurricane Andrew. And all 3 of these have been incredibly successful. Next slide, please. We're also doing some work in urgent and emergent telemedicine. I mentioned the telestroke before. We're actually one of the 5 academic providers for a for-profit company called Specialists on Call, who provides these emergency stroke services to, I think, close to 300 hospitals in 30 different states. We do a lot of work in teletrauma because our trauma center is so experienced and so well known. So we have a program with the State Department where we're actually serving facilities in the Middle East. But we also have been, I think we're now in our 2nd or 3rd year with a pilot program with Lower Keys Medical Center, because our trauma surgeons did a chart review and determined that they thought that something on the order of 30 to 35% of the helicopter transports from that hospital to our trauma center were unnecessary and could have been handled with a little bit of advice from trauma surgeons. That's gone very well, and I think Shands is part of that now too. Next slide, please. And we really see this as redefining the point of care. We're kind of turning the healthcare model, I wouldn't say on its head, but we're expanding where services can be located. Because if I can, you know, I've got a supercomputer in my waist, in my pocket, in my purse, well, not my purse, in one's purse, that we can really expand where services are provided, whether it's the home, whether it's the school, whether it's in your pocket or in the workplace. And I mentioned that we're doing this one initiative with the cruise lines for its employees, and we're actually putting our money where our mouth is and getting ready to start our own employee telehealth program for University of Miami. We're a large self-insured employer. Aetna's our TPA, and they've been real helpful in working with this and us in setting this up, and we're getting ready to start that up anytime now soon. We don't require that our employees use University of Miami physicians. So we have a little different business incentive to do that, because as a result, there's a non-insignificant amount of people that use non-University of Miami specialty services. So we're both looking to keep more of those healthcare dollars in our organization, but we're also looking to improve the efficiency, because there's so much inefficient time spent away from work and seeking medical care. So if they can just walk across campus, see the physician, go back to the office instead of driving, parking, waiting, all that other stuff. So I understand these slides will actually be in the handout. My contact information is at the end. I just wanted to mention 2 more things real quick, and I promise to be quick. Next slide. So we really think that telehealth is really enabling to this whole advanced medical home concept, because we can virtually co-locate specialists, allied health providers, whether that's physical therapy, occupational therapy, nutrition, in the primary care setting. So that primary care provider can still be the quarterback, and they stay in the loop, but the patient can actually stay in one facility to do that. So we really think it enables this concept of advanced medical homes, ACOs, whatever model you want to use, this collaborative care model. Next slide, please. And I know this was discounted a bit by our opening speaker this morning, but we get, you know, our dogs and cats get way better customer service in their medical care that they get than we get in ours. So I'm showing a picture of a Department of Motor Vehicles facility, not in Florida, because ours are so wonderful. This is, I think, in California. Well, but I think that's the level of medical service that we've kind of been indoctrinated to accept, and I think that's starting to change as well. So as I mentioned, thank you for your time. My contact information is at the end. I plan to be here all day. Thank you.
Very good. Mr. Bond.
Hi, good morning. My name is Travis Bond. I do not have a slideshow, so the marketing department would say, when you don't have slides, do it in interpretive dance. So I will attempt to do our point of view on healthcare. We think that, and I'm going to use it, redefining the point of care. I'm going to borrow a term that he used. When we industrialized healthcare, which we did in the 20th century in the US, we industrialized everything. We mass-produced everything. What we did is we took the doctor out of the home and put him in an exam room. And what happened was this sort of war on disease had huge collateral effects on the patient and their family, because in the attempts to industrialize healthcare to make physician and surgeons and other times more, efficient on a permanent basis, was that we now ask patients to go and see them. And so in redefining that point of care, we lost the social framework and the safety net of the family being able to talk about and support people at the time of disease and sickness. And so what happened is that we think that we really kind of broke that whole level of communication. And I know that when people think about healthcare and they say, okay, $2.8 trillion, you know, and these just massive numbers and 18% of our US economy, well, it's part of, I guess, you know, the penalty we've paid for to create the best healthcare system on the planet. But at the same time, if you really look at each of the things that we've done to sort of mess up healthcare as we've attempted to fix it, we've really broken down communication at all the levels, right? If you think about the TV shows that we grew up with Marcus Welby's and others, you know, it was the family doc and the surgeon. Now we have like 300 specialties. And so we have broken down the granular levels of what people will practice and what they can see efficiently, such that we've walled gardened each of those pieces of information that really belong to the patient. And so one of the things you learn in med school is to listen to the patient. 80% of your exam should be the subjective, meaning we're really going to get a big story and why that person's here. But the problem was that in the pressures to industrialize, to see more, to do more in a less amount of time, the average amount of time that a person is interrupted by a physician is 10 seconds. I mean, you can't even really understand what their name is and their age and hear their chief complaint in 10 seconds. And so the challenges, I think, to do more in less time have really kind of deteriorated communication. So why we're a big fan of telehealth and redefining these things that now are technologically possible is because they go back and improve communication. And so whether I'm seeing you on a Skype screen or some other embedded technology, or I'm talking to you on the phone, or I'm viewing your notes through some type of mobile or web-based technology, we're really starting to go back and clean up bad communication. And as we get doctors to talk to one another, they start to fill in the rest of the story. And so what our company tried to do is that we came from a background of creating EMRs that ran in browsers to give access to providers, was that we recognized really is what we had done and how we'd really got to a lot of the waste in healthcare is that patients were being told to do something and they couldn't remember what they were being told. And they could not tell their family, and so therefore the message was lost outside the exam room. So things like telehealth, things like mobile records, things that are now possible because three great forces are creating this sort of perfect storm that we've never seen before. You know, healthcare reform, age of consumerism. I love that. Think about that for a second. We were taught as capitalists in the US, as we created this country, we would vote for our dollars. We'd like one service over the other based upon what we paid for it. But guess what we have now? We have a whole nother ism, if you will, and that's like Amazon-ism and Yelp-ism and Foursquare-ism, in that we can now vote digitally. And so these forms of communications that the newer generations are now taking as just commonplace for them. I mean, I don't know, I'm pretty sure that my kid would not even know what the Encyclopedia Britannica looked like or a phone book, right? But yet, that generation, for the first time in recorded history, will live less than I will. They will die statistically sooner than I will die because we are getting sicker. So these things are important. So we should take the efforts legislatively. We should take all of our abilities from a technology standpoint for redefining the support structure in a family with information at points of care and sort of be pro that. The pro-ism is to really get everybody to communicate. So I think I challenge you in the audience in whatever part you're playing in healthcare, whatever technology is doing, let the legislation permit. But recognize that healthcare really is about communication. Whether you're communicating something to a trauma surgeon in a helicopter or whether you're trying to communicate to a 7-year-old who's freaking out because they have 104 temperature, it's all about communication. And so I would just say lastly, when we think about, at least from CareSync, and I think where evolution is going, is that we are getting back to a person-centric world, where Facebook and Instagram and our audiences are important because they reinforce the message. So as we continue to now add new waves of communication and what we will tell the patient, they need to store it, and it needs to go back to their story. Because if they're never given more than 10 seconds to communicate their story at a point of care, that time becomes critical to say, I am Travis, I am 46, father of 5. These are the things you need to know about me because I've never had chest pain before. So let's take that in context. Oh, but yeah, I forgot to tell you, I was out hunting and I ran 5 miles yesterday. it's things like that that they would really need to know. But if I never get that part of the story out, they're going to work on every other body system because they never even thought about a prior day's stress. So it's things like that. So I just challenge you to really look through the lens of communication and trying to sort of repair healthcare as part of that our war on it to improve it. Thank you.
Thank you all very much, and I'll kind of give a legislative perspective on that, is that in relation to everything everyone has said, I think it's a very exciting time in healthcare. We know that throughout the evolution of different industries, there are always a bell curve of people that go from early adopters on one end to kind of the out of sight, out of mind on the other end who never really fully adopt it. And in healthcare, we've kind of jeopardized that bell curve model among our populations because we never really gave the active consumer, the healthy seeker, the person who was the thought leader in their peer group, the chance to really go and see what is the best way to have healthcare provided because we've almost artificially stunted that pursuit. Now there's technology available that allows us to let those folks become the thought leaders in their peer group, to show what's possible. Technology exists to do a whole lot of things much more efficiently and with a great deal amount more care than we currently have it proposed. And so I'm excited to announce that this week the legislature, at least the House side, has filed House Bill 751 dealing with telemedicine. And the exciting part of that bill, albeit it's a very short bill, it's only 2.5 pages compared to some of the other ones you might see, really defines the framework around which we will think of telemedicine in the context of delivery and service. And the two very exciting words that are in that first part of that bill are synchronous and asynchronous communication. And so to define that a little bit more broadly, it says synchronous communication is, and for lack of a better term, I'm sure there are some people that will probably cringe when I say it, it's a Skype visit, it's a FaceTime, it's something where you have a direct connection over some kind of communication vehicle that's not just the telephone and it's not just email. There's also defined asynchronous communication in there as being part of telemedicine. And so as we've heard with things like LifeLens or Store and Forward, imagine that there is some kind of healthcare event happening right now. Somebody's having a seizure, maybe they're having a heart attack or a stroke, and you can capture that on camera, on video. We do it all the time with all kinds of social events in our life. Who's to say that now the reaction doesn't become that you start recording those things as they happen? You can then store that and send that to a physician who can then review that as part of the medical record. The legislation also defines that each one of these visits should be defined and recorded as a normal medical visit. I think it's very exciting for the state of Florida to not only, I think, catch up with some other states that are already doing this, and if anybody else wants to comment on that, but really start to acknowledge that we are finally allowing citizens, many of whom want to be healthier. There are folks out there who want to be the thought leaders in this. I know everybody knows the person they would call if they needed to buy a new cell phone or get a new TV because you know they've read up on the latest and greatest. There are going to be people out there who are going to want to help you and your neighbors and your community be healthier by taking advantage of the technology that exists today. And this legislation, I think, will allow us to take that leap forward to do that in the state of Florida and really redefine us as a place to want to be and want to live and hopefully have folks practice medicine because we're one of the healthiest states in the union. So with that, I think we'll open it up to questions. We'd be happy to entertain anything from anyone in the audience, and I think we'll have folks walking around with a microphone if anybody has a question after that.
May I make a comment while we're waiting for,
Sure.
for questions? Just in response to what several people said, the point about family caregivers is incredibly powerful. Because anybody who's ever dealt with a dying family member or a family member with Alzheimer's or dementia realize what an absolute critical aspect the spouse, the kids are. I know when my father-in-law was dying at home, it was like 4 of us around the clock for days before we got hospice there. And that's kind of a forgotten part of the healthcare system. So the second point is I wanted to applaud you on the 2-page legislation. You could
I didn't write it.
You could have found.
Thank you. I did not write
You couldn't. Why use 2 when 7,000 pages would do? But I think the point, and I haven't read the latest version of it, but I think the point that I would like to make is if we just stop thinking of telemedicine or telehealth as a separate thing and just as healthcare and treat it the same way, not as something different or something lesser, then I think that's a big step. And it sounds kind of like that's what you're talking about here.
Certainly, and I see we've got the microphone coming over here to the first person with their hand up. If you want, you can just shout it out and we'll repeat the question. Close enough. There we go.
Good morning. Thank you for that interesting presentation. My name is Lori Shirley, and I am an advanced practice nurse. Paul Keckley this morning warned us to accept no part of the status quo moving forward in this changing healthcare environment. Every single one of our panelists today mentioned physicians and medicine, but no other healthcare providers were mentioned in the telehealth initiative, and I especially caution us if we're going forward with legislation to include nurses, pharmacists, physical therapists, other providers, because once it's written in legislation, as we know, it's very difficult to change.
And I can address that quickly and apologize for the omission. The last 4 lines of the bill that we filed says a non-physician telemedicine provider using telemedicine and acting within the relevant scope of practice may not be interpreted as practicing medicine without a license. So it removes that caution that says that this is only open to physicians, which should alleviate some of the concern.
And I would agree what he's saying. We are actually exploring those opportunities. How can we get nurse practitioners? How can we get physician assistants? And one of the models that we just set up, we went to an accountable care organization, and we have implemented and integrated our Now Clinic into their care delivery model, the urgent care model, the emergency department model, and Now Clinic. And we're using physician assistants and nurse practitioners in that model.
And I would say I was fairly conscious of using the word provider rather than physician. And we do a lot with nutritionists. It's not just nurses. We do a lot with nutritionists and occupational therapy and other things. I mean, absolutely, it's enabling not just for medicine, but for healthcare.
Certainly. All right.
Good morning. With CNOW Incorporated, we're a telehealth technology company who for over a decade have been successful at using our technology by providers to treat those with developmental disabilities, intellectual disabilities, autism. We get great reviews from the families, from the service recipients. The providers are happy, but not everything is sunshine happy all the time, right? And what I want to know is that perspective that we don't have. We're getting great reviews. What do we need to know as a telehealth technology provider to better promote the benefits and what we have to offer the medical community and primarily the patient community?
I would say educating the caregiver system. So whether you're an ARNP or whoever is sort of providing care, or the illustration, one of the things I think that you find that increases anxiety, which then decreases confidence, which then just really sort of destroys the model of communicating with these caregivers, is not including the family. You know, not having the whole story. So I would encourage you, as you continue to build out your technologies, is that you do not repeat the sins of our fathers in HIT. And that really is that we've created a lot of patient portal, but it's a one-to-one. And so in this one-to-one abbreviated, I can't correct it sort of environment with the data, it's sort of, imagine trying to manage an entire financial portfolio with an ATM machine. You can only ask it questions and print a receipt. And so I would just encourage you, and as this woman said, the caregiver network is very, very broad. Given an opportunity in the advancements of your technology to allow them to share their ideas, thoughts, and comments, I think it will enrich what providers are then getting in terms of a story, and I'm convinced that they're trained to deliver better care when they have better data.
Next.
I'm Anna Bosnick with Empower, and Representative Brodeur, you were kind enough to meet with us on the phone a week or two ago.
Yes.
We provide mental health and child well-being services in Central Florida, and we're very thankful for your bill, and there's also a companion bill in the Senate, and they very much speak to each other. And to speak to her, it does say all licensed individuals can practice. We are, as you know, as we spoke to you, we're at a standstill. The state is going through a Medicaid reform, and new providers or new, like Sunshine Health, who I know is here. We are being told that telehealth is not being allowed to be written into those plans because the Medicaid handbook is not passed yet for 6 years. We've been waiting for it. We're to the point, not only with that, when those new plans come into place, the current plans that have the 2 pilots sunset, there's no more ability to get paid unless that is addressed legislatively or with ACA. Can you help us in that at all?
I would hope so. Now that the legislation's out and we see what kind of scope that it has to it, that's a question that I think we can begin to start to answer now. I think the hesitation before was that we fixed the problem without having to find the framework under which we're going to operate. So now that we have legislation and it's relatively similar in both chambers, I think there's an opportunity for us to address that. Because certainly, as you saw with I think it was Psych Health, that is an area where, by which I think you have the easiest way into telehealth treatment almost immediately. So, yeah, I think we can deal with that. More questions? More questions? All right, well, one more. There we go.
I'm Leah Kennard with the President-elect of the Florida Nurses Association. Is there any possibility the title of the bill can be titled Telehealth rather than telemedicine?
That would be a question for the sponsor of the bill, who's Representative Travis Cummings. I think that would be something that would probably come up in the first committee stop, should that be something that you'd want to do. Mechanically, I think that's possible, but that would really be up to the sponsor. Anything else? All right, one more question over here. Thanks, Leslie.
I'm Dr. Jamie Heisman. I work with WellMed Medical Clinics, which is a part of Optum. One of the things I'm charged with doing, as well as integrating behavioral health in our primary medical clinics. I personally believe we've carved it out to a fairly well, where now the mental health and medical is so far apart based upon reimbursement even that it's very difficult to bring back together. But in terms of care transitions and costs and affordability and quality, we're going to have to bring it back. I'd love the suggestions of the panel members in terms of bringing behavioral health into primary care clinics, how you suggest or what's worked best for you, or what could be something that primary care physicians would listen to in terms of bringing telehealth to their offices. So both to create the patient-centered medical home model, but also we all know that depression is rampant, especially in seniors, and their inability to go to another site because of convenience is very difficult. Shame and stigma is a part of it. So I see telehealth as being the answer, but I'd love to hear the applications.
I can comment on that. And that whole idea, I mentioned the idea of being able to virtually co-locate other specialties and other clinical services in primary care practices. That whole term the whole term co-location actually comes out of the mental health community, where they actually put mental health providers in a primary care practice. So absolutely it makes sense to do that. And I've seen this work in two ways. And as I mentioned before I came to the University of Miami, I worked for East Carolina University School of Medicine and was a consultant to the Division of Mental Health and Substance Abuse Services in the state of North Carolina. And two of the things that were really successful were involved in actually virtually co-locating mental health professionals in primary care settings. So one was in pediatric telepsychiatry. So we actually had a virtual clinic in one of the largest pediatric primary care practices, and that worked very well. And the other one, and so that's kind of specialty focused, but that could be it could be a clinical psychologist, could be, a variety of different mental health providers. The other model, and this is where the fee-for-service payment kind of disincents this, because there's not really a way to pay for it, as far as I know. We had it grant funded, so we did it, where we actually had one of our, I think it was the chair of our psychiatry department, actually worked in coordination with rural primary care providers to help them manage their whole panel of patients. So they weren't getting involved in psychotherapy via the video link, but they were working with that primary care provider that may been somewhat uncomfortable with using psychotropic drugs, or they had patients that were under psychiatric care that had to do different things. So they would work actually in conjunction with that primary care provider, kind of as a mentor, but work on the whole panel. And maybe once a week, this is the whole panel of my patients, or and we were starting to do similar things in cardiovascular health too. But that whole idea of virtual collaboration between primary care and specialists and other health providers is really strong, and I think is one of the big arguments is mental health.
And you have seen some policy movements. A lot of the federally qualified health centers are required to have psychiatric services for the people of the clinics that are there. And there you're seeing that integrated model where you have the primary care services, you have nurse practitioners, and you have psychiatric or psychologist services for those patients all under one roof. And certainly that should be a model moving forward.
And I'll say that I spent a fair amount of time in family care offices during the course of my career. And one of the things we have to remember, too, is that a lot of family practice physicians, when they went to medical school and they did their residency, and for the last 20 years, they did paper charts. That's how their business operates today. Their last brush with advanced communication came when the EMRs started to come out, and they figured out very quickly that they were kind of pricey, that there were 10 or 15 different options. None of them talked to the hospital. A lot of them didn't have the options of changing dosages for patients, that there were dosages they really wanted to do. And so their reaction or their learning was that you should just wait for all this to work itself out so you can buy the system that talks to everybody. So I think over time, as we adopt newer technologies in medical school and in residencies and start to make this a standard of care that people learn from the beginning, you'll get a lot more access and adoption of that technology.
And that gets to one of the things you mentioned there, I think really gets to another issue. If I'm looking at this as a citizen of the state of Florida, one of the challenges I think is going to be the workforce development. I know there's a panel on that later, but specifically about how both on the clinical education side, but also in the support side of the health IT workers, including people that are involved in telehealth, we don't have a vast pool of them nationally, and we definitely don't have a vast pool of them in the state of Florida.
The big drawback for a lot of the providers was I have to take how many of my staff offline of doing their actual job for how many days to learn this new system, which may or may not work, and talk to the hospital. So I think there's a little bit of an evolution that needs to come with that, as well as the dedication of the workers.
But it's also, I think it's also an economic opportunity too, that if we're training people that have a specialty in health IT, let's say, then there's that industry that spins off of that as well too. We're recruiting people from other parts of the country to bring them to Miami to do this sort of thing.
Or anywhere in Florida.
Yeah, well, yeah. but actually HCA, because just nationally they're not providing this, HCA actually has their own internal academy for people, developing people in health IT. And I think that applies to telehealth. So I mean, that's one of the things too, is we can't think of these as silos either within health technology. It's kind of health informations and communications technology that includes telehealth and EMRs and all that other stuff.
Very good. Any other questions? Well, seeing none, I want to thank AIF very much for the opportunity and our panelists.